Welcome back to Beyond the Scope. Today's interview, we are having a discussion, a conversation with Dr. Brandon Bankowski. He is an obstetric gynecologic specialist that specializes in vitro fertilization. He has an organization called Oregon Reproductive Medicine, and he took us behind the scenes and told us about fertility, in vitro medicine, his background, and I found it to be a very stimulating conversation. I hope you enjoyed it as much as I did. Welcome to Beyond the Scope, and today we have Brandon Bankowski here, my friend and a physician here in Portland, Oregon, who specializes in vitro medicine.
Fertility.
In vitro fertilization.
Care, in vitro fertilization.
Okay,
yeah.
All right.
Yeah, thank you for having me.
And he's kindly indulged my new quest to learn about videography and digital media, and is allowing me to spend some time interviewing him and learning about his line of work. And so we're friends outside of this. Our daughters play lacrosse together, and Susan, his wife, is Bella, my daughter's coach, and so we have a lot of good times together, and so I really appreciate you taking this time today.
Yeah, happy to be here.
So we were just talking a little bit ago about your journey into your line of medicine, and why don't we start at the beginning? I know you went to medical school at Georgetown University.
I did, yeah. I was a biomechanical engineer at Cornell before that, and med school at Georgetown. And
So did you get a degree at Cornell?
I did. I actually graduated, yes. Yeah.
Okay, and then you went to medical school.
Undergrad, yeah. Actually, even before that, I went to the Air Force Academy, but transferred out of the Air Force Academy to go into Cornell, and really, at that point, learned that I wanted to focus on medicine. I was really perfectionistic coming out of high school, and I was just worried that that would be hard for me in medicine if I couldn't help a patient or couldn't save a patient. And I think as I grew up through my experiences at the Air Force Academy, I realized that sometimes you do everything you can, and sometimes things you can't control things, and things don't work out the way you intend. And
so your perfectionism pushed you away from the Air Force Academy?
Yeah.
How long were you in the academy?
About 3 months.
3
basic
months.
training and then school, and it just wasn't who I wanted to be.
Did you get through basic training?
Mm-hmm.
Really?
Yeah.
Wow, that must have been tough.
Yeah. It was fun. It was hard. It was an incredible physical challenge. I lost 13 pounds in the first 3 weeks.
Bad food or a lot of exercise?
A lot of exercise, and they're yelling at you the whole time you're trying to eat. If anybody at the table makes a mistake, the whole table didn't eat, and so and we were just.
So it wasn't a nurturing environment.
Well, I had a lot of personal attention. Let's put it that way. But it just wasn't who I wanted to be, and I was fortunate enough to have Cornell waiting, and then I got into engineering and biomechanical engineering, and that led really nicely into medicine. Engineering is a problem-solving based education, and many times patients come to you and they have a problem that they need help solving, and so the thought process that they teach you there is I found to be really helpful.
So before you started Cornell, or when you were in Cornell, were you already thinking medicine?
When I was in high school, I was thinking either an academy, a service academy, or going sort of a pre-med route. So yeah, those were sort of my possibilities.
So academy, like the Air Force?
Yeah, so I went to the Air Force Academy.
Was your father in the military?
My dad went to the Air Force Academy too.
Okay.
So there's a little bit of that too. Yeah.
Any physicians in the family?
Mm-hmm. Oh, first one.
Okay. And so you spent 4 years at Cornell?
4 years at Cornell, yeah.
And during that process, you were thinking, hey, I'm going to go to medical school. And
Yes.
do another 4 years.
Yeah.
Okay.
I actually had to create the major because biomechanical engineering is a common major now, but
Right.
they'd never seen it. So I had to work with the school and my advisors and everything to sort of put together 2 majors, essentially biology and mechanical engineering. And so I ended up taking, I think you needed 120 credits to graduate. I graduated with 152, simply because in order to take enough classes to satisfy both, I had to keep doing that. So it was a great experience. I got involved with there's a vet school at Cornell, and there's a medical school. The medical school is in New York City, but the Cornell campus and the veterinary school are in Ithaca, New York, upstate New York.
Okay.
So I got involved with a physician who was trained at Cambridge named Peter Nathaniels, and he was doing amazing research on fetal sheep, and as well as baboons and monkeys, and he was studying essentially what induces labor. And the question is, and it's a really fascinating question if you think about it, does the baby trigger labor or does the mom trigger labor? What makes more sense? And so what we were doing, and I was pretty amazing looking back to be an undergrad and be even a part of this, was we would do stereotactic fetal brain surgery on sheep. So we would essentially do a C-section on the mom, and we would bring the fetuses, half deliver the fetus, do stereotactic brain surgery, and at this point in time they were using different devices to focus on something called the paraventricular nucleus, which when essentially to summarize it and probably oversimplify it, speaking to a neurosurgeon now I'm getting nervous about what I'm saying, but they would burn out the paraventricular nucleus, they would close the head of the fetal sheep, put it back in, close the uterus, and if they did that in sheep, the baby would never go into labor. Essentially, if they let it go on long enough, the mom would die.
So they ablate the paraventricular nucleus.
Yeah, so they basically, I think we're one of the key groups to figure out that the signal to go into labor in sheep was originated from the baby, from the fetus, and from that certain part.
So when you did the surgery, did you put a stereotactic frame on the, and then did you image it? I mean, how do you know you were at the right place?
I guess it was just because they knew exactly like how many millimeters down you would go this way and that way, and they knew the general area.
Okay.
I don't remember that.
I mean, there was no imaging preoperatively or anything, so it just.
I don't think so. And maybe they had.
You just went in the same place.
Yeah, in the same place. Yeah.
Yeah,
but
interesting.
I was.
So the fetus is
I
a
was
signal.
20 years old. So, so the fetus was a signal. Now, what's interesting or unfortunate, and the goal of this in a bigger framework is, if you can figure out what causes preterm labor and the delivery of babies that are severely premature, perhaps you can prevent that. Now, the mechanism in primates is different, and so it's not the same thing. But for me to be in these fetal sheep neurosurgeries as a 20-year-old engineering student was just unbelievable.
So did your curiosity and drive towards gynecology and fetal medicine start then, or were you thinking, hey, am I going to be a neurosurgeon? Or what were you thinking at that time?
I was certainly fascinated by pregnancy. And
Okay.
just the miracle of life kind of thing. It is. We know so little about it, and what we know is just mind blowing. To go from a ball of cells to a baby and to have this all happen, it's just amazing. I actually was attracted into OBGYN, just honestly because I wanted to do international work. I ended up getting a master's in public health during my training, and I was really interested in traveling, and I had done a program in Kenya, Knowles course in Kenya, and so that interest, I knew that if you wanted to be really helpful internationally, you had to be able to operate. I didn't want to fully live in the OR. I didn't want to be, really a surgeon, because I liked other parts of it too. And OBGYN is a really nice mix. You've got, healthy patients, you've got patients with cancer, you've got patients who have surgical problems, you have pregnancy. So it was really attractive to me because of the variety of patients. And because of the surgical but not completely surgical nature of it.
Yeah, when I was at USC, a women's hospital, where they deliver like 15,000 babies a year.
Big program. Yeah, my mentors came from there.
Oh, really? Yeah. And I thought at that time, I was thinking, gosh, I might want to go into OBGYN, you know, because you get to do deliveries as a student, episiotomy repairs.
Yeah.
You feel like a doctor.
Oh, yeah.
And then I got hooked up with the neurosurgery guys in their program. But my concern, though, was that women would want to go to women, you know?
Yeah. So I think there is some of that. Although, if you're a good doctor, you're a good doctor, and you treat people well, people find that out.
I think I was naive in that, but that's my thinking at that time, you know.
In a primary care setting, that might be more true, and it might be why there's more OBGYNs that are female than male. In a subspecialty setting where they're going to a specialist anyway, I'm not sure it's as important to a lot of people. But
so you did your engineering at Cornell. You got hooked up with some excellent research. You went to medical school at Georgetown. Then you did your residency at Johns Hopkins.
Yeah, internship, residency, fellowship, everything was at Hopkins.
So you did a OBGYN residency at Hopkins, and then your specialty training was in?
Yeah, so that was with 4 years at Hopkins, and then Reproductive Endocrinology and Infertility is the name, or REI is the name of the fellowship, which is 3 years after the residency. So not quite as long as you did.
Well, total 7 though.
But 7,
yeah. That's what I did too. Can you explain what OBGYN is?
Yeah, so the care of women throughout their lifespan with regard to their reproductive organs is essentially gynecology. Everything from, are the menstrual cycles normal, are there anatomic problems with the uterus, and then the ovaries as well. Are they able to ovulate, to get pregnant, or do they have any problems with menopause, with hormones, these kinds of things? And then gynecology and obstetrics are commonly performed together. These days now, it's separating out a little bit. A lot of that is because of lifestyle. Obstetrics is difficult because babies come when they want to come, and if you're going to provide continuity of care to your patients, it's hard because it's 3 a.m. on a Tuesday, or so that can be hard. So, excuse me. There's more and more hospitalists that are doing just obstetrics on labor and delivery, or just gynecology, and so the old sort of doing everything is less and less. Once you go into a fellowship, there's a couple of possible fellowships: high-risk pregnancy, which is called maternal fetal medicine, oncology, GYN oncology, and urogynecology, which is problems with leaking urine, especially as women get older, and other issues, and then fertility. I was attracted to fertility because I thought that it was one of the most important things that especially a couple would do in their life. I really liked taking care of women, but I also enjoy having a couple that you're taking care of. The technological aspects of fertility, where we collect eggs with the IVF process and genetically test them, I thought was just fascinating at the time, and kind of it was a problem to be solved. It was a solvable problem, and I liked that you saw patients throughout the course of that problem, and then at the end hopefully had success and they went on their way happy and maybe came back 2 years later for another baby, but I really liked the time course. So a lot of the elements of it were really attractive to me.
Did you have a mentor during your residency that kind of attracted you toward that, or?
Yeah, I did actually. I was a little scared of when I was a medical student going into OBGYN as well, and then Brendan Burke was an OBGYN at Georgetown, who was just he showed me that it was cool, it was great, it was fine, it was, you do what you love, like go where, don't worry about what people say, and so he made it okay. And then once I got to Johns Hopkins, I really had 3 amazing mentors. David Nagy, who has unfortunately passed away, was a maternal fetal medicine specialist that my wife had done research with when she was an undergrad. She went to Johns Hopkins undergrad. He came from an engineering background. He just thought he just thought about, he was so far ahead of everybody in terms of clear thinking about what the future would hold. I remember as an intern when he told me to email the paper that I just helped him write, and he said just attach it to the email. And I said, what? I don't know what that means.
So when
You know,
put it in
19
context, what year was that? Yeah.
It was 1998,
Okay.
and email was new.
Yeah, it
and,
was nascent still.
You know, yeah. And attaching, I said, I don't understand. How do I do that? And he's like, there's a little button up here. You click, and then it just comes to me. But not that I mean that is so basic now. Of course, you know, my 7-year-olds could do it. But he was just so far ahead of everybody. Rick Montz, who trained at USC, was the best surgeon I've ever seen. And he actually passed away at 47 also. Both of them were running, actually. That's why I don't exercise too much, stay less. I'm 47. I got to get through this year. So, but he, when he would operate, the planes would just open up like a Netter anatomy book. It was just amazing. And he just had a bigger view of the world too, and just he's the kind of person that just inspired you. They did a Hopkins 24/7 reality TV show, What's Life Like, as a resident at Johns Hopkins, and they followed him around, and he's just amazing. And then the other mentor was Edward Wallach, who there will never be anybody who accomplished as much as Edward Wallach accomplished in our field. He was at the same time chairman of Johns Hopkins. He had something like 4 or 5 R01s going with the NIH. He had 17 postdocs in his lab. He was also president of what was then the American Fertility Society, and president of SGI, the Society for Gynecological Investigation. At the same time, all of those things. No one's ever done that. No one will ever do that. He was brilliant. I mean, the most important thing you can give people in life is your time. And to this day, I could call him up and he would spend all day with me. He is just such an amazing mentor in fertility, and really I owe a lot of just how I think about things and you know how I care for patients from spending time with Dr. Wallach.
So did you do your fellowship with him then?
Mm-hmm.
Oh, fantastic. So you mentioned Susan, your wife, was doing some work at Johns Hopkins, studying at Johns Hopkins.
Mm-hmm.
Is that where you all met?
We met in middle school.
Okay, that's right.
In Ohio.
Okay.
Yeah, but we didn't see each other in high school. We didn't see each other in college. And when I started at Georgetown, she had been working on the Hill, and then she just moved to Baltimore.
So you guys kept in touch though?
Not really.
You weren't texting each other, not then.
No, not really. It was funny because I called her mom to get her number, and her mom looked me up in the middle school yearbook, and her mom said, "You're going to be a doctor? Her number is 410 blah blah
really?
blah blah." And I said, 410? What's that? And she said, that's the Baltimore area code. And I was like, oh, she doesn't live in D.C. She goes, no, she lives in Baltimore now. And I didn't know where Baltimore was. It's 40 minutes away.
Right.
You know, but and so we eventually connected and we started dating.
So you called her up because you were interested.
Yeah, well, you know, she was cute, so,
She is cute.
She is cute, yeah.
Right.
So we started dating. It was kind of nice because right when it got really serious, she applied to public health schools, and I think there were 13 in the country at the time, and she wanted to go to Hopkins because she could stay 40 minutes away from Georgetown, and she got into 12 schools.
Wow.
Except for Hopkins. All except for
No
Hopkins.
way.
Yeah. And this, if I should probably kill me for saying it, but there was a lovely unaccredited night program at George Washington that I thought she should go to so we could stay close because we were really starting to hit it off then. And she looked at me, she goes, I got into Harvard. And she goes, I'm going to Harvard. And I'm like, but that's in Boston. She goes, bye. So we did long distance for a while, which was great because we both got to focus on the things we needed to focus to, and then when we got together, we would have fun. But
So you were at Hopkins doing your residency, and during that residency, you got married?
we got married as a fourth year medical student.
Fourth year?
Yeah,
Okay.
and then And then kids came during residency, and more kids came during fellowship.
So she was done with her Harvard stuff already by then.
She was done with her public health. She was working at the Johns Hopkins School of Public Health,
Okay.
which is where I was going to school, across the street from the hospital. And then she kind of one day said, "I think I'm going to go to law school." And it was after I came back, and on the dining room table was the LSAT book. I said, "What?" And she said, "I think I'll take the LSATs." And she took the LSATs, and she crushed the LSATs. And she applied to University of Maryland, which has an amazing health law program. And she put herself through law school while I was in residency at night while she worked.
Superheroes. How do
Well,
you do
she
it?
is. Yeah, we had a lot going on, but yeah. And then she worked as the chair of the IRB, so all research studies in academic universities go through an ethics board that has community members and doctors and ethicists on it, and those are chaired usually by a lawyer, many times, who knows a lot about bioethics. And so she chaired the IRB. She worked in that field at Hopkins, and then she came here to OHSU and did that for 7 years here.
So you finished at Hopkins, and then
Yeah.
you went to Portland?
Yeah.
Okay.
Yeah. So I
What's the story behind that?
well, it's a funny story. Our field is unique because all of the outcomes for the clinical treatments that we do are published on a national open database. It's called SART, Society of Assisted Reproductive Technology. So for the last 30 years, you could see which programs had the best outcomes or which laboratories for embryo labs were best. And so I knew that this program was a phenomenal program, had super high success
This
rates.
program being
Or what was called then the Portland Center for Reproductive Medicine, which is now Oregon Reproductive Medicine.
right.
So throughout my fellowship, 2002, 2005, I knew about this program. And they were posting for a job. I had an offer to take a job at Johns Hopkins as an assistant professor. And I never saw the posting for the job. My fellow below me, who was in the military, who didn't need a job, came to me one day and said, "Would you be interested in this?" And it was a folder talking about this practice. I'm like, oh my gosh. The practice at that time was Dr. Materi, the founder, and Dr. Heslop, who was a Hopkins trained doctor. And so I said, yeah. So I called them, and they're like, oh, well, why don't you come out to interview? And we didn't know anybody here, but I was kind of hoping that we could get some leverage to negotiate Hopkins up a little bit, and see a fun place and have a nice little vacation, right? And then I came out here and I saw what they were doing. I saw the practice, and I was absolutely just blown away. So I was like, oh my gosh, this is amazing. I want to live here. I want to be a part of this. And so I had to go home, and I had to tell my chairman. My chairman was a very intimidating man, Dr. Harold Fox. He was huge. He had these huge hands. He had this deep voice. I was a bit of a, not troublemaker, but I was kind of pushing the envelope as a fellow. And so I had to go tell him that I was going to turn him down and go to Oregon. And
So you've been offered the job.
I've been offered the job,
Okay.
yeah, both jobs now. and I said, well, maybe I can go out to Oregon, and I can learn how they do IVF, and then I can come back and I can contribute to, or maybe help run the IVF program at Johns Hopkins. And he put his giant hand on my little shoulder, and he goes, Brandon, at Hopkins we only lose people to two places, Harvard and Oregon, but nobody ever comes back from Oregon.
Really?
Yeah.
Isn't that something?
It's a direct quote.
That's a great saying from Fox. And is it because of Oregon Reproductive Medicine, or what was called then the Portland, that the people don't come back?
No,
Or because of Oregon?
It's because Oregon. It's the lifestyle. I mean, a large part of the Johns Hopkins anesthesia department had just come out. The chairman had brought a whole bunch of people to OHSU. I didn't actually even know that
Okay.
at the time, but they had lost a lot of obstetric anesthesiologists at the time, and I think he had some other examples. But he was a great mentor of mine too. Yeah.
Were the SART numbers better here at Oregon Reproductive Medicine than at Hopkins?
Yes.
And so that's what you were saying. Hey, I can learn how to do
Yes.
it there and bring that back to Hopkins.
Yeah, I mean we in 1999 when we built the other lab, and now 2015 when we built this lab, the focus was on creating the best infrastructure possible, and that along with the just sort of intuitive talent of our embryology team, and with the detail to the protocols that we used, created a system in which our live birth rates have been in the top 2 or 3% of the U.S.
So your numbers are still top.
Yeah. That's why our practice is unusual in that about 25-30% of our patients are international. They fly here from whatever country they're in for the IVF success rates.
Well, why don't you take us through, what you all do here at ORM?
Yeah. So when I joined, I accepted in 2004. I showed up in 2005. I joined about 26 people, probably. And we had a nice practice. We were doing about, in terms of an IVF cycle, which is one patient going through, we were doing probably about 400 cycles a year at that time in terms of how SART counts those cycles. Now we're about 140 people, and we're doing about 2,000 SART cycles. The growth in numbers isn't necessarily proportional to the growth in the staff, because one thing that's happened is the complexity of what we're doing continues to increase. And it's funny because you have to pick a philosophy in anything that you do. So our philosophy was to provide the best reproductive care possible. Well, what does that mean? I don't know. It means a lot of things in a lot of situations. But then it sort of evolved into the philosophy is that when we approach a patient, if they're going to do IVF with us, they're going to collect eggs, make embryos, put the embryos back. We want to maximize the chances that they have a genetically healthy baby the first time they do that. So that's how we think of everything. We're not the fastest, probably not the least expensive, but in our dedication to that mission for our patients, we have created an expert team, a streamlined process, and not only are doing regular IVF, we're doing 300 to 400 donor egg cycles a year. We're doing over 300 surrogacy transfers a year. We're doing genetic testing on almost 90% of all the embryos that we have, with the most advanced testing that it really exists.
Why wouldn't you do genetic testing on 100% of the embryos?
Well, we make it optional, and it's
because it's expense involved.
Yeah.
Okay.
Yeah, it adds about $4,000 to $5,000 a cost.
Okay.
For most patients, and so the younger patients might not benefit from it quite as much, and they're more cost sensitive to the
and their eggs are less likely to have a genetic abnormality. Is that?
Yeah, exactly. So just to better understand that, men and women are very different in terms of how they make their gametes, their sperm and their eggs.
Okay.
Sperm are very small. Men are very good at wasting time, so men make about 1,000 sperm a second, all day, every day, whole life, right? Which is, I usually joke why men are so tired all the time. It's exhausting, right? But the reason they can do that is because the sperm are among the smallest cell in the human body. The advantage of doing that is that whether a man's 20 or 30 or 50, the sperm are always made new. So they're about 3 months old when they're ejaculated. Women don't do that. Women are born with all the eggs that they'll ever have. And nobody knows why. I usually joke that I think women are much better at getting things done. And men are like, I'll do it later. But it's the biology, I'm sure. The egg cell is enormous. It is the biggest cell in the human body by far. To give you a sense of scale, you could fit about 70,000 sperm inside of a single egg. So it'd be very difficult to make a single egg every day. It's sort of like a key versus a car. Sperm's like a key, small, easy to make, doesn't really age. A car is a complex machine, an egg is a complex machine, right? Lots of moving parts. Complex machines of all types, computers, cameras, accumulate damage as they age. And women are born with them, so by the time they even get their periods and are capable of getting pregnant at 13 or 14, those egg cells are already over a decade old. But we don't, fortunately, in most cases, want to achieve pregnancies at that age. We wait now, the average age of getting pregnant in some states is over 30. And so now those eggs are 3 decades old. Well, if we genetically test our egg donors, who are all in their 20s, let's say 23, 24 years old, a third of the embryos that they create when the sperm and the egg DNA merge together and 3 billion base pairs come together to fertilize, a third of those embryos are genetically abnormal. They have the wrong amount of books of DNA, which are called chromosomes. The wrong amount of chromosomes. 1 out of 3, that's the best it gets in a hand.
In their 20s.
In a 22-year-old.
So is that what causes a miscarriage?
In many, it depends on what it is.
Okay.
In many cases, if, for example, there's a missing book, a monosomy,
Okay.
that won't even implant. It's just, you transfer it, it's just negative. In other cases, there's an extra book, like trisomy 16, 18, 22. These situations with extra books all miscarry. Trisomy 21 is Down syndrome. That
Right.
usually miscarries. But in some cases, it's in milder forms. It can be compatible with life, which is why you would see children potentially with Down syndrome.
So the monosomy, you're not talking about doing in vitro implantation. You're talking about even in just a typical pregnancy that wouldn't implant.
Exactly.
Okay.
In either case. In
I
either
gotcha.
case, yeah. But by the time you're, I mean, I have the statistics right over there, but by the time you're 34, 35, half the embryos you make are chromosomally abnormal. By the time you're 40, probably 80% of them are.
Wow.
And that is why fertility drops so much for women. That's why the age of the egg is such a big driver of this. And so if we're able to collect a bunch of eggs, and we know only some of them are mature, and only some of those will fertilize, only some of those will grow to day 5. The day 5 embryo is called a blastocyst. It's like a big beach ball. It's got this clump of cells in the middle that's called the inner stem cell mass, and that's what makes the baby. It's got a ball shell of cells called trophectoderm. That's what makes the placenta. We take a laser, we biopsy about 4 or 5 of the cells from the outside shell, the placental cells, and then we freeze or vitrify the embryo. We put it in liquid nitrogen in a specific way. The DNA from the biopsy cells are amplified, and that it's called PCR. PCR basically means we make more of it. We put it on a microchip. So this is a next generation sequencing microchip, and it allows us to put the DNA in, add in about 1 million genetic probes, and get a report back. So each embryo gets a report that tells you if that embryo has the right amount of chromosomes. If it's got extra chromosomes or missing chromosomes, then we won't transfer that. And we're transferring embryos that are either 46XX, which would be a normal female sex, or 46XY, which would be normal male.
And is this 100%?
There is no test that's 100%. Nothing in medicine is 100%. But for what this is looking for the chromosome abnormalities, the aneuploidies they're called, that we're looking for, it's very powerful, very powerful. And I mean, to give one answer, it's 99% probably,
Fair
or
enough.
in that range. Yeah.
So do all fertility type organizations do this?
Well, so it's interesting. It's a great question, and the field is trying to figure that out. For us in our program with our data, I can show you clearly, the last 5,000 cycles that we've done, that it makes a significant difference in the outcomes. But in order to pull this technology off, you have to really master at least four skills. You have to be able to grow embryos very well to the blastocyst stage. You have to be able to freeze them very well and thaw them with really high success rates. You have to be able to do the laser biopsy, and then you have to be able to figure out, with sort of the best genetic testing technology, where's your cutoff for normal and abnormal, so that you're really giving people the best answers. And if any one of those technologies is not functioning at the very top of its level, you're not going to be able to see the benefits that what we would call this process CCS, or comprehensive chromosome screening. You're not going to see the benefits of it. And so a lot of other programs that do this, but they don't show that it helps many people, their utilization of that is 15, 20, 30% of their cases, whereas ours it's 85, 90% of our cases, because it's been shown to help so many people and be such a powerful thing. It avoids you transferring beautiful embryos that are completely chromosomally abnormal and will only lead to negatives or miscarriages or terminations or something like that. And it gets you to the ones that really have the chance to make a healthy baby.
So when compared to the other centers that don't have that type of quality in that the whole program, do you see that there are less of those deliveries or abnormal deliveries or
Well,
losses?
so their overall live birth rate per transfer is
Right.
going to be lower. Their miscarriage rate per transfer is going to be higher.
Okay.
And I think that's one of the things that, to stay on really.
Statistically significant, though?
Yeah. Well, I think so. We see. I mean, if you compared in our program at any age group, success rates without testing the embryos versus with, significant differences across all age groups.
So it might be worth the extra 4,000 or 5,000 you said on the front end to make sure you get that.
Yeah, because one way to think about it is if it saves you from transferring the wrong embryo, it kind of pays for itself, because a frozen embryo transfer cycle is more than $4,000 or $5,000. So if it saves you from having to do a second one of those because you put back the right embryo in the first place, number one, you have a baby faster. You don't have to go through a negative, which is, horrible, or a miscarriage, which is even worse. And you get to that genetically healthy baby more efficiently, faster.
And certainly when you're 40 years old or even in the 30s, this seems like it would be something you'd want to do.
Well, I mean,
With
probably
half
at
of the
32,
embryos.
33, above that age, which 32 is pretty young, right?
Right. I wish I was 32.
I know, right? But above that age, the majority of embryos are abnormal. And this is why people aren't getting pregnant every month, and this is why miscarriages. Now, a lot of times people will ask, and you're probably going there, well, we don't see babies with that many abnormalities. And that's because the denominator is different, right? If you're looking at babies born, all the monosomies are out of that denominator because they never even implant. And most of the trisomies, the trisomy 16 doesn't have a name like Down syndrome because they're never born. It's incompatible with life. So, if you're saying, well, babies don't have these things that much, our denominator is per transfer. Every time we have the opportunity to help somebody achieve a pregnancy, we want it to have the very best chance of being a genetically healthy one. And, we are all in on that. We've got 5 full-time genetic counselors all over the world. We've got one in Shanghai, we've got one in Canada, we've got one on the East Coast, and they help our patients understand the benefits and the limitations of this technology. It's not perfect. Different clinics that are very good have different experiences with it, but we think it is kind of the state of the art in helping patients get to what our mission is for them, that genetically healthy baby.
And you do that all in-house here?
We do. We do the laser biopsies here. We amplify the DNA here. Right now, some of it is sent out to a core lab where they've got 4 of the really big machines and 12 PhDs that are working on it. But we want to have everything here, and we're moving towards that.
So when I hear that you're traveling over to, London or Spain or wherever you're going, you're bringing the eggs back here?
Oh, no.
Or they're coming here. You're meeting them. And the
Everybody
patient
comes here. Yeah,
I gotcha.
yeah.
Okay.
So, and that is because of 2 things. Number one is that a lot of what we do every day here is not legal in other countries. Compensated surrogacy you can't do in most countries of the world. Compensated donor egg you can't do. Genetic testing is not legal in some places. And so some of our patients just have to travel because they can't do, if they're a same-sex male couple from France, they're not allowed to do donor egg with a surrogate in France. So they have to travel, and they come to the United States because it's legally safe, because our success rates are the highest, and because they know to trust that process. I think if you are getting patients to the point where they're making this huge leap, right, over an ocean of uncertainty, right? Let's call it the Atlantic Ocean of uncertainty. There's really 3 things that they have to come to grips with to do that. Number one is that the idea of it is believable. that they know that they can come here, have a healthy baby, and take that baby back, right? And because we've done this so much, because we work with the best legal experts, that's pretty much understood in most places. The second is that you believe in the platform, right? Okay, I know I can come have a baby through donor egg surrogacy in the U.S., but is IVF with CCS the way to do it? In vitro with the genetic testing that they do at Orem, is that the way to do it? Well, that's what the SART data helps with. No other country in the world has audited live birth rates. So anybody really could tell you whatever they wanted to about their success rates. But they wouldn't have SART knock on your door and say, we want to pull these 100 charts and we're going to call these people and verify that they had babies like you said they did. And then the third thing, so one is the idea, the second is the platform. The third thing for that trust leap is that they put faith in a person. And that's a big reason why I go to travel, is to see them, because I can Skype with people very efficiently from all over the world, but it's not like sitting on the couch and talking to them in Israel or London or China. It's really meaningful and important to go to them and explain it to them personally. And there's a couple of conferences that are around the world that bring together groups of experts. We're starting to put these on ourselves now that we have such a big following in places, where we deliver what we think is the state-of-the-art information, because a patient, whether they're a gay couple or it's just somebody who hasn't had success from Belgium or Amsterdam or they might just not know what's available.
So when you travel to Israel, you're going there really just to meet couples.
Yeah.
You're not doing anything.
No, I don't. I mean, I don't have a license to practice medicine in Israel.
So that's how you can do that. You just really get to know.
I just talk about what I do. I say hi to we have a bigger and bigger party now where we've helped about 300 families from Israel.
That's really.
Yeah, and so we have somewhere around 260 babies born, I think, and there's about 50 babies that are cooking right now. So
when you go back, do you visit with some of those families?
Yeah, so we have a big picnic, and it gets bigger and bigger all the time, and
so you're developing a worldwide community.
Yeah, it is. A lot of what we do
is
about developing community. Yeah. Because
so you're making friends all over the world.
Yeah, we're lucky.
And the most personal thing there really is.
Yeah, it's an amazing part of what we do. So.
And your other partners do this as well?
Yeah, Dr. Hesla and I were the ones that have done the vast majority of it. But my other partners, Dr. Barbier and Dr. Herleman, are starting to go to our China office and to other places as well.
Wow, what a job.
Yeah, it's the world's shrinking, right? It's you should go to the best place, right? You should go to where you have the most confidence, because to do something this important, which again is really expensive, there's a lot that goes into it, and you really want to go to the best place. That's what people don't understand. I learned that in Ohio. I went to high school in Ohio, and my neighbor Bill was this great old guy. Loved him. Lived across the street, and he needed a coronary bypass. He needed I think he had a problem, maybe a mini stroke or something. I don't know, because I was young, and he needed like a 3-vessel cabbage. Like he had to have a big heart surgery. 20 minutes north of our house was the Cleveland Clinic. At that time, they had over 50 cardiac ORs. Now I think they have over 100 cardiac ORs alone. Just operating rooms devoted to heart surgery. And they had princes flying in from Saudi Arabia, and they took care of presidents, and I mean, it was the place in the world to go. 20 minutes south of us was Akron General Hospital, which also did cardiac surgeries, and maybe a couple a week, and had one OR and a couple doctors that used it. And he ended up going to Akron instead of the Cleveland Clinic because he liked his doctor. And he had a complication, and thank goodness he was okay and everything. But I remember, I didn't appreciate that fully at the time, but that wasn't the best choice. The statistics on outcome data in medicine clearly show that when you do more of it, you get better at it. You pick up the subtle things. You have less complications. And the Cleveland Clinic was I would go to the Cleveland Clinic if I needed that surgery.
I would too.
Yeah, exactly. So. The same thing is probably true in neurosurgery. You go to the people that do those cases, right? It's certainly true in fertility.
Right.
Not all clinics are the same. And it's not just the doctor and their hands, it's the whole embryo lab and then the whole team below it, the genetics team, everything below it. So that is an important lesson.
Well, can you take us through what a typical patient? I mean, you're a father of two 7-year-old boy twins that were conceived through in vitro technology, right?
Yeah. So I have to mention the other ones too because they'll get mad if I don't. So, but we didn't have any trouble with having our first two kids, my son and my daughter, and then my wife got older and. We waited a little while, maybe too long, I don't know, but then we had miscarriages and then negatives, and then we did inseminations, which are the simple treatments. They didn't work, and then we did IVF, and we had a miscarriage. And this was right before the genetic testing really hit.
So just to go back, because I'm curious.
Yeah.
So you tried inseminations where
Yeah.
they would inseminate the egg with your sperm?
No, so a woman ovulates, she takes some pills of Clomid or letrozole, she takes some pills, you figure out when she ovulates, you get a sperm sample and you kind of put it up in the uterus. So it's the simple level of treatment before IVF. And that didn't work, and the success rates with that treatment are much lower. It's much simpler, but much lower. And so we got to the point of doing IVF, and luckily I know a few people in the field, and was very fortunate to have one of my partners, Dr. Hess, to help us, and we had miscarriages and got to the point where we transferred really the last embryos that we had.
So you had harvested some eggs? Yeah,
she did IVF a couple times.
And then did you in vitro inseminate the eggs?
Yeah.
And did you test the eggs?
No, it was, this modern testing platform, that chip I showed you, it's about 5 years old. Okay, my twins are 7.
Okay.
So
you certainly would though if you had it.
Oh, now absolutely. Every single one of us, my partners, would do that if we were going through now. But the generations of technology prior to this were not.
So this is really cutting edge last 5 years.
And the genetics have exploded. I mean, the continuing education you need just to stay on top of the genetics is a big part of what we do, just to stay at the forefront of the field.
So you had your 2 boys,
Mm-hmm.
which are beautiful, perfect boys.
Troublemakers.
Naturally. But they're twins. So how often do you get twins when you do in vitro?
Well, so it's interesting because the one big disagreement that I have with the SART data is that they say that this is not meant to compare programs, but that's what everybody uses it for. And then they'll say, well, ORM transferred an average number of 1.4 embryos or 1.7 embryos or whatever, and they'll give you the success rate. But if you were my patient, you're not going to transfer 1.4 embryos. You're going to transfer 1 or 2, and those outcomes are very different. 1 embryo has a probability of success. Okay, LeBron James. Okay, everybody knows what his free throw percentage is. Why? Because he shot 10,000 free throws, and we know that he makes 70% of them. Well, if he gets 1 shot or 2 shots, he's more likely to score with 2, right? Because it's 70% plus 70%, right? So the same thing's true with embryo transfers. We present the data. If your age, with tested or untested embryos in our program, over the last couple of years transfer 1 embryo, this is what the outcome has been. If you, in your age, tested or untested transfer 2 embryos, this is what the outcome. And say, to simplify the numbers, let's say it's 70%, right? 70% live birth per transfer. Any embryo can split into twins, monozygotic, identical twins. So if I just put back 1 embryo, that's about a 1% chance. But
so 1% that they'll split.
Yeah.
Okay.
But if you transfer 2 embryos, then it's not just that 70%, because either one might implant, or both. Excuse me. And the live birth rates are higher in the 85-90% range. But about 2/3 of those are twins. So, and those are twins because each embryo has its own chance to implant. Those are fraternal twins, as you might say, so they're not the same genetics. They're not split and sharing the same blood flow. Identical twins, which we can't control, are much more complicated, much more dangerous. But the big concern about transferring 2 is that the chances of going into labor early the chances of having a premature baby, the things I was talking about at the start of the interview, those are increased. The cost to society, the cost to the patient, cost to insurance are increased. And so the field, if you look at it, the average number of embryos that has transferred used to be 3, 2.5, 2. 3 years ago, we transferred in some populations an average of about 1.8. Now we're transferring about 1.4, telling you that the majority of patients now are doing single embryo transfers. Not everybody, but whereas a couple years ago, the majority of patients were transferring 2 embryos.
Because the ones you implant are surviving.
Right, exactly. And they're surviving at higher rates, especially in our program, because we're doing so much genetic testing. So the only embryos we're putting back are ones that have the right amount of books of DNA to start.
Right.
Yeah. And the goal is, realistically, from an overall good standpoint, the goal is that you transfer 1 embryo and you have 1 healthy baby every time you do it. That's the theoretical goal. But right now, it's there's patient autonomy issues, right? Right now I'm not telling you that you have to transfer 1. Right now I'm identifying, if you do 1, it's this. If you do 2, it's that. We talk through the risks and benefits of both and what you want to prioritize. So we transferred 1, it didn't work, and then on our last transfer we transferred 2 and had our twins.
So go back to Susan and your twins. They're identical twins.
No, they're fraternal.
Oh, they're fraternal. So both eggs.
Yes.
Okay.
Both embryos.
They look so, blonde and cute together, right?
Yeah.
And I'm not that smart, so.
They're it's
Different
amazing
twins.
how different their personalities are, though. It's
Well, even identical twins have different personalities.
Right. Yeah.
So it's only 1% of a viable egg that becomes twins in the general population typically. And it's no different when you implant than when you
Right.
do it
I mean,
naturally.
there's some data says it might be a little bit increased in IVF, but there's probably some biases in that data. So it's about 1%. Yeah.
So let's go through what the whole process is for
an
some-
IVF?
For IVF, yeah.
Yeah, so essentially what happens naturally is that a woman's brain sends down a bunch of fuel to get a group of eggs to be recruited to grow inside the ovaries. And the eggs grow inside of these little follicles. They look like little black circles on an ultrasound, so the ovary kind of looks like Swiss cheese with these little holes in it. But the brain doesn't want 20 follicles to ovulate 20 eggs and a woman to get pregnant with 15 babies, because the uterus isn't designed for that. She might get her own reality show. Wouldn't be good. So the brain lowers the fuel. Most of them die. Whichever follicle is the best one, whichever has the most receptors for the fuel, keeps growing. So out of those 20, 19 die and 1 grows to maturity and ovulates that egg. Next month, she recruits another 20, 19 die, 1 ovulates. When we do IVF, we want to make it more efficient. A big study showed that about 7% of eggs turn into babies. So if we only got 1 egg, it wouldn't be very successful. So we give more of that fuel, the FSH. The FSH fuel, that egg fuel, it's placed from the pituitary, the brain, into the bloodstream. It's not stable to withstand your stomach acid, so we can't give you pills of FSH. We have to give you shots or injections. They're called gonadotropins. But we just give a lot more of it. So if she recruits 20 instead of 19 dying, we get 20 to grow. We can't make a woman have more eggs than she has. We can just get the ones that are there to grow. If she only recruits 7, we're only going to get maybe 7. And when we do the
So how many eggs are in the ovary?
millions, but
okay.
each month you
20
recruit, and as you go through the years, your follicular pool is smaller and smaller.
Fair enough.
The average 25-year-old recruits about 25 eggs.
Okay.
The average 35-year-old recruits about 15 each month. The average 40-year-old recruits about 10.
Okay.
But more and more of those are getting abnormal as
Okay.
you age. So we give the shots. We monitor it very carefully for about 10 days with ultrasounds and blood work to make sure it's going in the best way. And then it's about a 15-minute surgical procedure with a needle and an ultrasound under anesthesia to go in and collect the eggs from each follicle on both ovaries. So today I did 4 egg collections. I got 94 eggs.
So that's done transvaginally?
Transvaginal, needle
Endoscopically?
aspiration. Yeah, through the tissue that's at the top of the vagina right into the ovary. So
And with an endoscope, can you see what you're doing, or is it just aspiration? You're
it's
just
it's
not
a
blinded?
it's an ultrasound.
Oh, so ultrasound guided needle.
Yeah.
Okay.
There's no surgery. It used to be done a long time ago, laparoscopically.
Okay.
But it's just an ultrasound. We have great pictures, and you can see the needle go right in, and so.
And can you see the eggs on the ultrasound?
No, eggs are microscopic. You can see the follicles.
So-
So the needle goes in, the follicle goes like that.
You can
and
see it
goes
shrink
next.
down.
Yeah.
Okay.
Yeah. So one patient I got 34 eggs because she was young donor, and the next patient was 43. I got 2 eggs.
And how soon do you know how many eggs you got?
Well, so the eggs come into a little fluid in a test tube. It's handed to the embryologists in
Okay.
the embryo lab, which is like a special
Which you have right here.
box. Yep, which is right here. And then they look under the microscope and they ring a little bell so that we know we got the egg.
Okay.
Yeah. Then they take the sperm and fertilize them. They grow those for 5 days.
And when was a sperm? It could either be from the partner or a donor.
Correct. Yeah. Yeah.
And so, how long is the sperm been frozen?
Some cases, yeah. So some cases we thaw it. In other cases, we just get a sperm sample from the partner that day.
Okay.
And we put them together. The next day, only so many of those eggs were mature, only so many fertilized, and then we grow them for 5
And
days.
you just pour the sperm on the eggs, and it does its thing.
Sometimes they take a sperm and inject it right in. That's called ICSI, intracytoplasmic sperm injection.
Okay.
And if we're worried that the sperm's not going to fertilize, we'll do ICSI.
So you're worried because of the sperm viability, or
If the
this-
numbers are low, if they've never had a pregnancy, if it's been frozen before, different reasons.
Okay.
Yeah. And then the embryos can be transferred at day 5, or we can do that CCS biopsy where we test them and freeze them, and then we do a frozen transfer where we get the uterus ready with medicines and we thaw them and transfer them.
So when you transfer them after they've been frozen, they're still a day 5 embryo.
Right. Yeah. Yeah. Day 5 blastocyst. It's the stage of implantation. It's the time when that embryo is ready to attach, and it needs more than you can give it. If you start, there are programs that have transferred day 7, day 8 embryos, and they just start to decline. At that point, if that embryo is not attached to the uterus, it doesn't do well. They get too big, and they need to develop the placental blood supply to keep growing as the baby.
So how do you attach that 5-day?
So
cell to the uterus.
The same way with the vaginal ultrasound, we also have abdominal ultrasound probes, and so we place a speculum, we scan abdominally with a full bladder so that we can see what the uterus looks like, and we take this little straw, which is called catheter, and we place it right into the right place and lay down the embryo right there. So
Yes.
it's called an embryo transfer. It takes about 10 minutes.
And it just attaches right away.
Well, the implantation is a process.
You have to
know.
kind of hold it up against the wall there for a while, or what
You
do you
know,
do?
so one analogy about that to kind of understand that, because everybody thinks they're going to stand up and it's going to fall out.
Right.
One analogy, which came from actually a USC guy, but it's sort of like a speck of dust inside of a jelly sandwich. So if you stand up, it's not going to fall out.
Okay.
The hydrostatic forces of the endometrium in opposition hold that embryo where it needs to be, so that's how we can do the transfers. But we have our patients go on bed rest for the next 36 hours during the process at which that implantation happens, because we really want to just minimize the contractions that happen in the uterus, and we want them to be relaxed. And again, that's been, I think, part of the reason why our success rates have been high as well.
Does the uterus have it's pretty collapsed in non-pregnant state? It's not a
Well, yeah, but we're giving hormone levels.
Yeah.
We're giving exogenous or extra hormones to thicken the uterine lining so that it's at its most receptive time.
Oh, because
when
the
we
body
do
doesn't
the
know it's going to be
transfer.
pregnant.
Yeah.
So you have to prepare it as
so
like it's pregnant.
Yeah. So most of the cycles that we do are medicated cycles where we give you estrogen and we measure it, and then we give you progesterone and then we measure that, and on a set day at a set time, that's when the embryo goes in.
So someone comes from Israel, a couple comes here, and you've already met them and talked to them about that, and they start the process here. What's the whole timeline? How long are they here?
Well, so the patients that travel to us, if it depends on what they're doing, right? So if they're doing, if it's a same-sex male couple, they're just here for a day or two, So we can get the sperm frozen, they can meet the whole team, have their genetics consult, their psychological, their consult with the psychologist, sit down with me, talk to the team. If it's a heterosexual couple from France and they're coming to actually do the IVF,
Right.
they're in town for about 2 weeks.
From harvesting the egg
Taking the shots, doing the egg collection, because that testing process.
and impregnating them.
Well, if most of the international patients or patients that are traveling would be doing the genetic testing.
Right.
That's why they're coming here. And that would require them to be transferred at a different time. So they come twice, a couple months apart.
Okay.
Yeah.
How long does the genetic testing take?
We can rush it in some cases, but the best way to do it, it takes about 10 days.
And so you said early on in the interview, 25% of the people that you are helping are international,
Yeah. We have.
and probably just growing.
Well, that's growing. We have a growing national presence too. It's kind of funny is that we focused on Oregon, and then we just happened to focus globally, but we sort of left out the United States.
Right.
You know, and so we're focusing more now on New York and a lot of the other cities. In many things, people naturally think, oh well, New York, LA, they must have the best, whatever.
Sure.
Best restaurants, best fertility care. The fertility care is great in those places, but it's not necessarily the best. So we actually see a lot of patients from New York City and DC, and we're seeing patients from Florida now, a lot of California patients, a lot of Washington patients.
When you talk about the statistics with LeBron James, when it's an Oregon patient, do you use Damian Lillard?
Of course.
Are you selective?
Of course.
So
The international patients is who I use that with most, and they
Is
don't
that-
know Damian Lillard. So
that's right. That's right.
I know he's your neighbor, and it's no offense to Dame, but yeah, they
It's for no, it worked. That
Yeah,
worked.
yeah.
So what I wanted to ask you is, I sent you that article about how there's a movement towards making IVF more accepted as far as insurance.
Mhm.
How does that affect you, or how do you feel about that? Getting the insurance
Oh, I
world
think it's
involved
great.
in
It's
your work?
actually so my master's thesis was about studying the impact of insurance mandates. Some states have a mandate that says if you live here, we will cover you for this much IVF. And I studied the effect of that, and it has a couple effects on the population of the state. One is that it increases the age of first birth. Massachusetts was the first state in the United States that has the average age of a first baby over 30, and that's because so many fertility treatments. Massachusetts also has the most liberal coverage for IVF. It also takes a lot of the financial pressure off, which has the effect of allowing a lot more citizens of that state to do IVF, so the per capita utilization increases. When that happens, the programs become massive. For example, Boston IVF has 18 doctors and 8 satellites, and it becomes much more protocol based, or you could call it a factory if you want to be critical, but much more protocol based, because it has to be, because there's so many thousands, there's 9,000 people going through IVF every year in Boston IVF. And when that happens, and I showed this in the data, the live birth rates drop, the success rates per treatment decrease. So it's not good or bad. It's certainly it's unfortunately quite a technologically advanced process that is expensive for a lot of people. So to offer insurance coverage, about a third of everything we do is covered by insurance here, but in Massachusetts it's a lot higher than that, right? And so you get a lot more people who can access the care, which is great. But the impact systematically on the care that's delivered changes, because instead of me seeing 10 new patients a week, maybe I see 40. And can I see them all? And so it's it just changes what you do. There are only so many fertility doctors. There's about 30 fellowship spots a year, meaning there's 30 new fertility doctors a year.
Right.
Not all of them are doing clinical medicine, right? A lot of the older guys are retiring now because our field is about 35 years old now. So it does change things. That's the effect. I mean, do I think it's great to have more people be able to access it? Absolutely. there's more and more things that we can help. The success rates are going up and up, but it does change it when it does change the practice, or at least that's what my research showed. Looking at the really heavily mandated states that are covered by these insurance things.
It's not like you're looking for more work. You got plenty of work.
I have 4 kids. I got plenty of work.
Yeah.
No, it's it's a really incredibly rewarding field. We play a really important part in people's lives. We're so fortunate that that people put their trust in us for this, and that means a lot to us. I mean, having been through the process and knowing the trust I have is important, but it's okay. It's okay. But our systems are designed to hire the best people and let them all care for everybody as they go through. It's unfortunate, there's a lot we don't understand about why in this patient the biology didn't work, or why in this patient the genetics are abnormal, and so we want to help everybody, and the science isn't there.
What's the percentage of people that come to you that will come away with a healthy baby?
I mean, almost everybody, if they listen to what our recommendations are. If you're a 43-year-old and you've had 4 miscarriages and you come in and I look and there's 2 eggs there, the chance that you're going to have a healthy baby with your eggs is probably 1%.
Okay.
If you do donor egg, and if I recommend that you do donor egg, which I would have to do in that situation, or donor egg with genetic testing, the live birth rate per transfer on the first transfer is 65% for one embryo.
Even without a surrogate.
Right. It's not the age of the uterus that really matters.
Okay.
Now, if you had a destroyed, damaged uterus from multiple surgeries, and every time we transferred nothing happened, we would recommend a surrogate. If you won't go to a surrogate, then we probably can't help you. So, but using donors and using surrogates and using genetic testing and using our ability to test for specific diseases that might be in the family, like cystic fibrosis or Tay-Sachs or things like that. I mean, if you will do what are the appropriate medical indications, it is a very, very successful process.
What keeps you up at night? As far as your work goes?
So as any business grows, you have growing pains, and we have an incredibly high touch, high technology, complex business. To scale the quality of that is a challenge. For example, one of our competitors, pioneers in the field, fantastic. I'm not going to say who it is, but
in Oregon?
No.
Okay.
In another state. They sold their company to private equity group for a tremendous amount of money, and decided that we'll scale it and we'll open 12 centers with this name on it all around the country. Well, that might be great, but it's not like a massage clinic or a physical therapy clinic where there's a lot of providers and you're doing one set of services. Like, where are you going to get 12 trained reproductive endocrinologists? And that's only if you have one in each center. Where are you going to get that many trained embryologists? Where are you going to get those genetic counselors? How can you maintain the quality of that? It was interesting to watch The Founder, which is about Ray Kroc and McDonald's.
Right, I saw that, yeah.
But he went to one of his McDonald's that he hadn't been to in a while, and they were serving barbecue chicken and corn on the cob, and he's like, "This is not what we do. We make hamburgers."
Right.
And so it's maintaining the quality of what you do is much more important than scaling it incredibly fast. And even if your lab processes are fantastic, that's just a process. You need the talented people to do it. It comes down to the people. And so we're always trying to provide improving care at the highest level to more people that we see. People get pregnant, they send us their friends, and we do this in different places, and that means we have to go into some of the businesses that supply us so that we have control over those for the patient, right? And we have to stay up with the genetics, and we have to make sure that as we bring more and more people on and it grows, that the core of it, the core values are the same, and that those are maintained, and the accountabilities for that have to be in the right place. So it's there's always a lot to think about, but that's the part I like too. It's it's creative, and there's not necessarily a defined answer, and that is a really kind of stimulating place to be, because it's not like you can open a book. Nobody's ever done this like ORM has done this. So I can't call my buddies in the field and say, well, what did you guys do when you did this? Because they've never done it that way.
Just the whole multidisciplinary, bringing everything in-house.
Multidisciplinary, international clientele, diversified, vertically and horizontally integrated service lines. There aren't any examples. There's big corporate examples that are somewhat similar, but those big corporate things really streamline what they do to one core service, and they're not doing donor surrogate genetic testing of an international couple.
Right.
You can't streamline that. That's why we have 20 people behind the scenes on that one cycle for that one patient. But so that is it doesn't keep me up because I'm worried about it. It keeps me up because I'm engaged in it and I enjoy it. And
right.
Just thinking about how to do that better and where we need to go next to continue that mission.
Well, Brandon, I want to be respectful of your time, so I really appreciate you spending some time.
Oh, thank you.
You've
Thank
been
you.
great.
This was fun. I appreciate your questions.
You've been great. Thanks a lot.
And you did a pretty good job too.
Well, it's all you, man. Thanks.
You bet, buddy.